Hello everyone, I am Yaqub Nadeem Mohammed, PGY1 at St. Joseph Mercy Oakland Hospital. Today I am going to present a case of reactive angioendotheliomatosis associated with alcoholic hepatitis in a young woman. Brief introduction. Reactive angioendotheliomatosis is a rare disorder associated with intravascular proliferation of endothelial cells. It can be idiopathic or associated with systemic diseases like lymphoproliferative, autoimmune, hepatic, and renal disorders. We here present reactive angioendotheliomatosis associated with alcoholic hepatitis. Our case is a 28-year-old woman with a recent diagnosis of alcoholic hepatitis and persistent reactive leukocytosis presented to our ER with pain, erythema, and swelling in bilateral inner thighs for 2 weeks. The lesion started as a dark spot, progressively worsened without improvement after 5 days of cephalexin. The ulceration became worse with severe pain. The patient denied fever and chills. On physical examination, vital signs were normal. General examination showed pallor, significant jaundice, abdomen was distended with palpable splenomegaly. Bilateral lower extremity showed 2+ pitting edema. Skin examination showed erythema of inner thighs measuring 8 into 5 centimeters on the right and 12 into 7 centimeter on the left with central black eschar and multiple small vesicles as shown in the figure 1. Lab evaluation hemogram showed macrocytic anemia with hemoglobin 10.8, MCV 106, WBC 28,000 with neutrophils 16,000. Hematocrit and platelets were normal. Peripheral smear examination showed mild anisocytosis, reactive neutrophilia, and lymphocytopenia. Renal function was normal. Liver enzymes were elevated. Total bilirubin 22.5, direct bilirubin 9, ALT, AST, and alkaline phosphatase 157. Inflammatory markers ESR and CRP elevated 68 and 8 respectively. Blood cultures time 2 was negative. Viral studies including HIV and hepatitis were negative. Autoantibodies ANA, C-ANCA, P-ANCA, and antimitochondrial antibodies were negative. Imaging studies like vascular ultrasound lower extremities ruled out. Deep venous thrombosis, CT angiography lower extremity did not show peripheral arterial disease. Surgical biopsy revealed epidermal and dermal necrosis with intraepidermal vesicular dermatitis. Hospital course, patient was initially started on vancomycin and piperacillin tazobactam for suspected necrotizing fasciitis. Wound and blood cultures negative. Autoimmune and imaging workup was negative. Skin biopsy confirmed diagnosis of reactive angioendotheliomatosis. Antibiotics were discontinued and patient was started on oral prednisone 60 mg daily for 3 days and her symptoms improved. She was discharged on oral prednisone 60 mg daily for 1 week followed by a tapering dose. And she had a follow-up appointment in 3 weeks and 3 months in our clinic. Showed resolution as shown in figure 2 on presentation at 3-week follow-up and at 3 months. Discussion regarding angioendotheliomatosis. It is a benign condition with vascular proliferation and tend to occur in patients with coexistent systemic diseases like infections, hematological disorders, monoclonal gammopathy, and vascular abnormality. Change in hemodynamic and local hypoxia cause complement and IgG mediated vascular injury and reactive angiogenesis. Histopathology will show benign intraluminal proliferation of endothelial cells. There is also a malignant variant called angiotrophic large cell lymphoma, which is a rare extranodal lymphoma with CD20 and CD79 positive. Here are my references. Take-home point for internist is to realize the rare occurrence of angioendotheliomatosis in association with systemic diseases and consider biopsy to confirm diagnosis. To avoid repeated admissions and recalcitrant cellulitis. Repeated debridement and antibiotic overuse. This condition requires treatment of underlying systemic diseases, antibiotics in presence of infection, and corticosteroids. Thank you.